Yeah. All right. Guys, so we're starting our last unit here today. Congratulations. That's it. So here we go. We're going to be starting this last unit, which is the reproductive system. And here we go. Have any questions for me? What I'd like to do, and I think I started recording, did I? Yes. Okay. What I'd like to tell you is that what we'd like to maybe do, just to get it out of the way, and also be another lab, because that's not a significant part. So these labeling of labs should be helping you with your grades. So what I'd like to do, we're about to talk about the male reproductive system, and I'd like to separate this male reproductive lab into two parts, male and female. So we'll do the male by itself. Now this looks like a lot of structures, right, to talk about, but we're going to end up talking about all of them in just the next few minutes, really. We'll end up talking about a ton of all these structures and how they play a role in the male reproductive system. And this is what I'd like you to be ready for instead of a lecture quiz, though you should also be studying the lecture, because this last test will be coming up here soon, like next week, correct? So you should be studying that too, but be ready to get a 100 on this. This will be at 9 o'clock on Thursday morning. So no lecture quiz? No, but here you go. I want you all to be ready. Be studying, because that test will be the next Tuesday on male, female, and even some senescence issues. So, okay. So this will be your lab, all right? Now, so we're going to talk about reproduction, and obviously we'll start with the male system, then we'll go to the female system, and get the basics for this and understanding this. We understand that sexual reproduction is actually the major way that most multicellular organisms or complex organisms actually reproduce. And the reason is that sexual reproduction requires two parents contributing DNA to offspring to the next generation. And with that adds diversity, adds the ability to maybe in the species for some to survive. Even if a great parasite happens to come in, it won't wipe everyone out. Some will potentially survive. And if those few survive, then life can go on for that species. So this adaptive type of traits have actually been what has been, is what is now used by most multicellular organisms. Bacteria are single-celled, aren't they? The protozoa are single-celled. So these single-celled organisms that still use asexual reproduction, that's one parent, and that's a type of cloning. What does cloning mean? It means you're making a copy, right, of yourself. So one parent just really essentially dividing, then two new cells are identical to what the parent cell was. So there's still many species on the planet, because we know that actually 80% of the life on this planet is actually single-celled bacterial life forms. Many still use a type of cloning, like prokaryotic fission for bacteria and asexual reproduction for some of the eukaryotic organisms. But multi-celled complex organisms mostly use sexual reproduction because it gives an adaptive advantage, okay? Now, we're going to talk about how humans, Homo sapiens actually do. We have two sexes, so we have the male and the female. And in Homo sapiens, in humans, the male produces sperm. This is the same in all species, but anyway, in humans, the male produces sperm, and the female produces what we call an egg. Is that right? So y'all already know that. You also know that in humans, you guys remember from our genetics study, that humans carry a total of 46 chromosomes. That will be considered normal, right? But can we think of them as individual chromosomes, or because we're sexually reproducing, how do we think of our chromosomes? In pairs, where we get one of each of the pair from our mom, and the other one of that pair we get from our dad. Now remember that. So 23 pairs of chromosomes. A total of 46. What we know is that in the gonads, which are going to be sex organs, we talk about males have testes, females have ovaries. We understand that there's a special kind of cell in these gonads called germ cells. And when y'all hear the term germ cell, you cannot be thinking of something like bad that causes disease. Germ actually just means actively dividing. That's what that means. So in gonads, when we think about germ cells, they are the cells that have a diploid number of chromosomes, meaning a 46 total, 2 at each of the paired sites, these germ cells. And they're going to undergo, these diploid germ cells are going to undergo a very specialized type of cell division called meiosis. Meiosis is that special kind of division that is only happening in the germ cells of the gonads. That's the only place it's happening, meiosis. And meiosis is going to end up, that type of cell division is going, after the divisions have happened from the germ cells, the cells that are going to be produced will have half the number of chromosomes. That's called a haploid number of chromosomes. We call those cells gametes. Gametes in males are sperm. Gametes in females are what? Eggs. Everybody remembering this? Jogging everybody's memory from inheritance and genetics that we talked about in ANP1. If it's been a while since you've been to ANP1, review this. Review this terminology. We'll have it on the test, the final test. So meiosis, where is it happening only? Gonads. What type of cells in the gonads? Germ cells has what type of chromosome number? Diploid, which means a pair at each site, right? But after meiosis happens, which takes from a germ cell 2 divisions to get to 4 cells, what are those 4 cells called? What are the 4 cells called? Gametes. And in males they are, and in females they are eggs. And we understand that the chromosome number in those cells is of what type of number? Haploid number, which means that how many total chromosomes are in there? I just swallowed a bug. I have a pet. Okay, but what's that number? 23. It's only going to be 1 other pair. So that means that ladies, think about this. I can talk about it, discuss now since there are no men here. Ladies, think about your eggs and think about the germ cell that becomes your egg. So that means that you only sent 1 from each of your parents. So you started with 46 in that germ cell, but only 1 from each of those pairs got to go down to that egg. And even before that happened, your moms that you got from your mom, that homolog at that paired site, got with your dad's chromosome from that paired site, and they wrapped around and they switched whole parts of their genes before they then sent 1. And what do you get what I mean? The diversity is phenomenal. It's phenomenal that happens. It's sexual reproduction. It's sexual reproduction. What kind of special cell division is required for it? Meiosis. Right. Okay, so any questions from me so far? Now, again, this is a little bit, well, no, this is, but anyway, so here we go. When you talk about primary sex organs, they're the gonads. Testes in males, ovaries in females. I had a student one time say, ovaries aren't gonads. They're like, and I think they used a slang word for testes. But I was like, well, yeah, we have ovaries. They are gonads. Yes, they are. Okay, so these are our gonads, primary sex organs. But Kate, if that's all we had, if we didn't have the integrity of these other ductwork, could sperm ever get out to do its job? No. Could the egg ever move down the fallopian tubes into the uterus? And no. So we've got to have all the ductwork happening. We have to have all the secretions we need happening, contributing to semen for men. And then also everything that a woman needs to keep the integrity of these structures going. So these secondary sex organs are also important. We can't discount them. And then also secondary sexual characteristics. They actually attract members of the opposite sex. You know, everybody in this room has been attracted to somebody you know darn well intellectually you should leave alone, right? But what happened? You just had this incredible pull, right? But guess what? That's actually nature. That is actually natural that happens. Okay. Anyway, so in all of that lower voice, that when men hit puberty and their larynx is targeted, right? Their muscle mass is targeted. Beard growth, axillary pubic hair, same in females. You might not even consciously realize it, but a tone of a male's voice can be just enough to do it for you, right? And you're not even consciously realizing that that's the case. Pheromones from these glands that start secreting, the sebaceous glands and pseudoriferous apocrine glands that are being put off. You're not conscious of being aware of those scents that are in the air, breathing in their molecules that they're releasing. But that's attractive to the opposite sex, right? So all of this stuff is happening. It all needs to happen, and that's a good thing. There is a typo here on this slide, and I couldn't fix it. It wouldn't let me change the graphic. But I want you to think about women right now, and you said that we have 23 pairs of chromosomes, right? In our germ cells, 23 pairs. But when the germ cell undergoes meiosis, at that 23rd site, just at the 23rd pair, what makes a female? What's at that 23rd pair? What are those chromosomes called? They're called sex chromosomes, but they're called X and Y. Remember? So women have what there at that site? They have X, and then they have another X, right? So when a woman's germ cells in the ovaries undergoes meiosis, that woman can either give one of the X's or can give the other of the X's, right? So a woman only has what to give? An X to eggs. Only has an X to give to an egg. But males, when they're making the sperm, males' germ cells in their testes, as they undergo meiosis and half the number of chromosomes go to each of their sperm, a male, half of the sperm will get the X and the other half will get at that site the what? Y. So we said we understand it's whatever sperm gets to that egg that dictates the what? The sex of the offspring. It's the male gametes that dictate the sex of the offspring. And so if you didn't remember that, please do remember that, all right? Now, any questions for me? Maybe we also remember that on the Y chromosome, on this Y chromosome, there is going to be a little region on the Y that's actually called the sex region of the Y. It's referred to as the SRY gene. And if the Y chromosome is there, then this SRY gene is going to be active only for a few minutes of time in that individual's life, in the embryo's life, only for a few minutes. What will happen is during those few minutes of time, that gene gets turned on and it starts flooding the embryo with testosterone-like hormone. And that testosterone-like hormone will act on certain tissues in the embryo, and that embryo will become a male. In the absence of the Y chromosome, that would mean there's no SRY gene, because there's no Y chromosome, you become a what? So we had talked about how we become females kind of by default, don't we, in the absence of this. So good. Now, so in embryonic development, when you're thinking about early on, by the way, what's the first cell that's created when a sperm penetrates an egg? What's that cell called? A zygote. Then that zygote undergoes what kind of cell division when you're making a copy of yourself? Mitosis. That cell divides and starts to divide in a fluid-filled sac. The first 2 weeks of those cells dividing that are in the sac is called a blastocyst. Around the 6th day after the zygote is formed, this group of cells enter into the uterus. And if implantation happens around the 6th day after fertilization, then you're pregnant, right? But for the first 2 weeks, it's called a blastocyst. From 2 weeks to 8 weeks is an embryo, you remember? From 9 weeks to birth, it's a fetus. From birth to about 6 weeks is a neonate. Are we good with that terminology? So remember that terminology. This is going to be important for you to know. Everybody good? Okay. So early on, though, as an embryo, sexually, they're not different. But if this little embryo gets flooded with that testosterone-like hormone, then we know this embryo is going to become a what? It's going to become a male. So at 7 to 8 weeks, look, it's already affecting the tissues on a male here, affecting the tissues differently in the absence on a female. So if you actually look at birth, the difference in the male gonads and the female, it's almost like a mirror symmetry, isn't it? The structures that actually become a penis in a male, the tissues, they, in the absence of that hormone, become the clitoris in a female. The structures that become the scrotal sac that holds the testes, the scrotal sac, those tissues will become the labia, the lips of the genitalia, the labia minor and major in a female. So these tissues, they're going to actually continue to develop based on what hormones they're exposed to, right, or the lack thereof. So anyway, just so you can kind of see this is all FYI. I don't ask you too much about embryology because that's like a whole class in science of itself, but just so you guys have the basics of this. So when we think about these tissues and how they're kind of looking, like I said, I don't ask you all too much about this, but you're seeing at 12 weeks, can you already see a difference in this sensory organ in a male versus the sensory organ of a female? So you can already see that. Now we understand what's happening, and why it's happening as an embryo and fetus, okay? So we get that this is genetics. We get it's that 23rd pair of chromosome, the presence of the Y chromosome and the SRY gene, especially, right, or the lack thereof. But now let's just think about males first. So we're going to talk about males, and we understand that when we looked back at this structure of males at birth, we understand their gonads are external to the pelvic cavity, aren't they? So these gonads are no longer in this pelvic cavity region, and they are actually external. For that to happen, then we've got to have a descent of those testes. And those testes are going to have to descend. Now, obviously, we have a right testes and a left testes, right? So this is bilateral. This is happening. But those testes have to descend through an area called the inguinal canal. Inguinal meant what? We remember our lab about regions. What does inguinal mean? It's in the pelvic. See, y'all can do that too. It's the groin, right? So the inguinal canals, you've got these canals. Now I need for you all to see, this looks like there's just and obviously we're just seeing one side, but this looks like, okay, so there's a testes there and it looks like ductwork is there, doesn't it? But please keep in mind, there's a lot of important structures that are moving through that inguinal canal. Don't these tissues need blood supply? Mm-hmm. So we've got arterial blood supply. We've got venous return, don't we? How about lymph? Mm-hmm. Yeah, so we got to have lymphatic. Hey, how about nerve supply? That's got to be there too. There are a lot of important structures moving through this canal that need to move through this canal. Most males, their testes have descended at birth. So when you look at their scrotal sacs and palpate them gently, you don't even have to palpate them. You can actually see the testes inside that sac. But if you palpate, if you can't see it, palpate it gently and see, make sure you feel that testes. Some boys, they don't descend. About 3% have undescended testes. That's a pretty significant number, actually. And actually higher than that have floating testes. What would that mean? Yeah, they kind of will slip back up in there, and then they'll be. So you might be changing a diaper, you know, and you know that the testes are in this girdle sac. You can see them, you know. But then all of a sudden you're changing the diaper of your 2-week-old male boy. You think, is that flat? Like a flat? That's flat, you know. And so what is happening then? They're maybe floating. That needs to be documented, that needs to be watched, and that needs to be addressed, because if testes don't come down and stay down, if they float or get stuck or don't come down, they'll die. So this is a significant thing. Undescended testes is called cryptorchidism. It can definitely be addressed and it can definitely be fixed, but it has to be diagnosed first, you know, so people have to know what they're looking for. All right, any questions about that? Cryptorchidism. This is here. Okay? Means undescended testes. They can be, it's in your notes, y'all can look this up. So what they'll do, if they decide they do need to do surgery, if they decide they don't all need, sometimes they'll watch them and, you know, and then they'll see if they stay down after a bit of time. But anyway, what they can do is they can go in and actually pull the testes down and then stitch around this canal to close it up. Is there a risk to that? Yes. Because what did I just tell you is coming through that canal? A lot of important structures, right? There's also things that can happen like hydroceles. I don't know if y'all have heard of those, but you can get like a separation of some of the tissues and fluid can form as a little, like a little pocket, but could that fluid put undue pressure too on this area? Yeah, so, okay, great. Now, and maybe this also shows you, since males have had this area that's had to accommodate those important structures, that this is kind of a weaker area in the lower pelvic wall of a male. So males are much more prone to having inguinal hernias, aren't they? Inguinal hernias, where a part of the intestines will actually slip through that canal. And we said a hernia is when organs, it's usually intestines and or stomach, an organ will push through a muscle wall, right? Everybody knew what a hernia is. Probably heard of inguinal hernias, right? The danger of a hernia is that it can strangle the tissue. So those tissues can get strangled and circulation be cut off, and you have an ischemic attack, which ischemia means what? Ischemic attack means what? Lack of blood supply, and the tissues can die. And if the tissues die, they can become gangrenous, and it's like to hell in a handbasket. We don't want that happening, do we? Okay, just trying to get people's attention. Okay, so great. All right, now the men's perineum, this area that we refer to as a perineum, we usually don't think about this area for men. We think about perineum for what? For women. And you see kind of the same sort of area. But anyway, so I'm just going to tell them that. So there you go. Here we are. We're at this slide. Y'all ready? Is this a slide you need to know for Thursday morning? Okay, is this for these structures for the lab? I might not be this picture, but it's, you know, it'll be close. So okay. So this is what you'd like to look at. Now this is a mid-sagittal region section. So what does that mean? Mid-sagittal means you have cut it from and separated right from left. So we understand what we're looking at here is just the right testes, right? Correct? The right testes. So we understand that. And we're looking at this mid-sagittal region. We said we already kind of get that males have shared structures from their urinary, don't they? So see this bladder here? This is the bladder. And what was this tube that's going to carry urine from the bladder out? Urethra. We understand that this urethra is going to be a shared structure with the reproductive organs. That's different. Women don't share structures, do they? Between urinary and reproductive, but men do. When men are ejaculating, there is a valve that closes here, so urine does not mix with semen. You know, so it is a coordinated kind of autonomic nervous system response. So, okay, but we're looking at this, and we already know about the bladder. We already know urethra. We came in here knowing that. We just did the GI tract, so do we know what this is? Yeah, so we've got the rectum and we've got the anus. Is that right? So we know that too. Maybe you can see why men often have what type of exam to palpate the prostate gland. This prostate gland that has been sliced, but the prostate gland that completely surrounds this part of the urethra, this prostate. What kind of exam do men have to palpate that? And you can see that they have a rectal exam for that, and that's why, because it's close. You know, it's very thin kind of tissue that separates that. So that's why they have that type of exam when needing to examine the prostate. Okay, so we already know some structures, don't we? And I think most of you know the scrotum, right? Your textbook describes it as a pendulous pouch, which I think is just beautifully poetic. I wish I could claim that, but I didn't claim it. It's a pendulous pouch, kind of is. All right. And anyway, inside the scrotum there is the testes, and then we're going to talk about the other structures now kind of going. So, you ready? I think I can do most of this chapter's lecture from this picture. All right, so not all of it, but most of it. So let's take a look at what's happening. We know the primary sex organ for male is the testes. We know that this gets targeted by two hormones at puberty that from the pituitary gland that travel here to sort of turn this testes on at puberty. What are those two hormones from the pituitary gland? FSH, which stands for? Which is going to target the testes for the production of sperm, and then LH, which stands for that targets the testes special cells in the testes to produce testosterone, which also is going to even help with sperm production. So this is awesome. So we know at puberty, the turning on of this testes is going to light up, really, and it's going to do that because of FSH and LH. Everybody's good with this. We know this, right? And these are going to target testes for those reasons. Testosterone secretion is going to go up. All of those secondary sexual characteristics that we think about with males at puberty are going to happen. It's a lot happening, isn't it? A ton happening. And we know the sperm is going to be produced here. And this is outside the body, right? This is outside the body. But how the sperm going to travel to be able to exit the male's body? They have so far to go. I mean, really think about the poor little things. So anyway, they're going to be sent through ductwork. And that ductwork is really coiled here. It's called the epididymis. This epididymis is a coiled little tube that if we stretched it out would be so crazy long. But anyway, the sperm are going to be finished off, produced, kind of finish off their processes in this epididymis and stored here. And then there's going to be this tube that once it's stimulated to contract, there's going to be peristaltic contractions of this tube, this ductus deferens, also sometimes called the vas, V-A-S deferens, vas deferens. What is peristaltic contractions? This little muscular tube that's got a lumen opening that sperm are going to move through. What do peristaltic contractions do? Move things in what? Yes. So coordinated peristaltic contractions. Look how far sperm have to go. They have to come all the way back up into the pelvic cavity. There is, when it gets here close to this area, the seminal vesicle is going to secrete part of the semen that's going to help it along its way. The prostate gland is going to be secreting into these ejaculatory ducts. The prostate gland secretes about 30% of semen. The semen. The seminal vesicle is going to contribute some. The bulbourethral gland, this little gland, is going to contribute some, because only about 10% of an ejaculation is actually sperm. The other 90% is the fluid that's helping it to go, to be transported, right? But it's not just helping it to be transported. We're going to see that in semen, there's going to be protective substances that are going to protect the sperm along the way, help to provide energy for the sperm along the way. So when you think about an ejaculatory event, I want you to realize only healthy, normal adult male, it's only about 10% of it is sperm. The rest of it is all these secretions that need to be present, and the amount that they're there to help the sperm along the way. So here you go. Let's go back here for a second. But peristaltic contractions we knew about, didn't we? This stuff is deferens. Have y'all ever heard of a vasectomy? And what is a vasectomy? What's happening in a vasectomy? Vasectomy typically means removal of. So what's happening in a vasectomy? Alexis will make them sniff it. So vasectomies can happen in a urologist's office visit. It is a, easy for me to say, it is a quick procedure that is a low risk. There's never no risk to anything that's invasive. But it's a low risk procedure, takes minutes to do, can be done in an office setting of a urologist. Of course, there's two, so do one, you gotta do the other. But anyway, what they're doing in that office visit is palpating the scrotal sac, and they palpate the testy, and they can feel at the top of the testy where this duct is, and they kind of manipulate it close to the surface, make a superficial incision until they can see the duct. They do cut that duct, and there's different techniques, but they can band. After they do a cut, they can band and band, and there's different techniques used by different urologists. But the reason this is done is for what? Birth control. So birth control, ladies, we always have it seems like the onus is on us. Isn't that right? Yes. Men are as responsible for their reproductive futures as women are, and they need to account and own that. And women do too, but men do too. So anyway, and this is a procedure that is, relatively effective. There have been some failures, but most of the failures have happened because people think that they're ready to go then, or when the swelling goes down. Because there's going to be a little bit of swelling. It may not be ready right then. But anyway, they're ready to go soon. But actually what happens is some of the sperm hasn't finished off its process yet and can be in this duct. And so they tell you at 6 weeks, and this is where the failures have happened, you have to practice other birth control for the full 6 weeks time, and then go and have a negative sample that's given that had no viable sperm before you're allowed to use this as your control, right? As your birth control. So that's when problems have happened, is that people think, oh, well, it's been whatever weeks, we don't need to use anything else, we're good. And then, no, they're not. So, okay, good? Is everybody good? So that's the vasectomy. Now, so now like I said, we've gone back up into the pelvic cavity. You've gotten secretions from the seminal vesicle, from the vulvourethral gland, from the prostate gland. This gland has been cut for you, but it's a walnut-shaped size gland that completely surrounds the ejaculatory duct and the prostatic urethra. This is called the prostatic urethra because the urethra is moving through the what? The prostate, right? So as men age, what is typical to happen to this gland? It can enlarge, and that can just be a typical thing of aging. Sometimes it enlarges because it's infected, so prostatitis, y'all have all heard of that. They usually don't even do cultures, they'll just use broad spectrum antibiotics. It usually is bacterial, but the bacterial cause can be more than one organism. So because it's such a difficult sample to get from the prostate, men don't really like you doing that too much to their prostate. Because it's a difficult sample, because it could be expensive, they usually will just do a broad spectrum antibiotic to treat that. But this gland can just, as a normal process of aging, kind of enlarge. When it enlarges, what is it closing down? Remember, the urethra is going through that has a lumen that carries urine and semen. But as this prostate enlarges, what's it doing to it? Squeezing it. And so it can actually lead to incontinence issues or frequency issues. The frequency issues can lead to potential infection, and because they're not completely emptying their bladder, and then that can cause issues. Alexis, do you have a question?
Yeah. What did you say that it surrounded again the
prostatic urethra. It's just called the prostatic urethra because it's the part where the urethra moves through the prostate. And this is called the penile urethra because that's the part of the urethra that's moving through the penis. Exactly. Are we good? All right. So I do want to let you all know, and I think you have insights about it, but you should know anyway because I do ask you about it. You know, I think young women at puberty are told a lot, or hopefully are told enough about, you know, breast development and also menstrual flow and menses. So they're explained to you about some of these things. But you know, and hopefully also get explained to about knowing kind of their bodies. So doing monthly self-breast exams, right? Young boys should also be explained to that they should do the same types of exams. The type of cancer that can happen to young men is testicular cancer. And it can be, if there's any, boys should know to look for any types of nodules, any types of soreness, or whatever, and it needs to be addressed. Testicular cancer is more often seen in young men, but it can be cured if caught early. It can be deadly if it does what? Spreads. So if it's caught early, they will remove that testicle, but the man has another one. You know what I mean? So it's not like they're going to become infertile. They still have an. So anyway, they'll save their life. In older men, and this is what I want you all to hear this. In older men, if a man lives long enough, they will have prostate cancer. If a man lives long enough, almost all of us will develop prostate cancer. But please hear me when I say this. Not all prostate cancer is created equal. Younger men, 40s, 50s, and even 60s. That's younger. I know y'all think of it as 60s. Younger men have more aggressive types of prostate cancer, so they are going to be more aggressively treated. Is that right? But if you've got a 75-year-old who comes in and has developed prostate cancer, and they need to do some testing, but if it's the typical one that happens in older men, those men will die from something else before they will die of prostate cancer. So please encourage your people you work with, the people you know, if they have developed prostate cancer as an older male, that they really need to evaluate how aggressive their urologist is going to be with them. Because you can imagine removing that prostate gland is probably going to cause issues with incontinence. It's going to cause issues with sexual, you know, whatever. And I know a lot of people are still having sex with them. Yes, some are. So actually a lot are. And it can be devastating for people who have aggressive surgeons that probably should have never touched them. You see what I'm saying? Now, if there's a younger male that develops prostate cancer, and again, prostate cancers need to be evaluated, and y'all probably heard of Gleason scores or whatever, but they do evaluations on this. And honestly, people need to use a common sense kind of approach before burning down the barn. You know what I mean? I've just seen this happen so many times over the last several decades. When it was determined, and I remember this was in the early 80s, when it was determined that men will develop prostate cancer if they live long enough, guess what happened to research dollars? Guess where research dollars started to go quickly? Guess what happened within the first couple of years? They had a blood test for it. Guess what the leading cause of death in women? Breast cancer. 1 in 8 women will develop breast cancer. That means they're all happen, but they'll develop. Do we have a blood test yet for breast cancer? Guess what this is about? Sexism. Somebody said. Well, it's about research dollars and who's controlling research dollars and where research dollars go. But it really is about that. It truly is about that. Now, what the men did that were controlling this, and that's really true. I'm not trying to be sexist. Don't look it up. So I was there. I was part of that research stuff that was going on at the time. But it was really just really almost comical. But what ended up happening is that men got so aggressive. They were like, because if you think you have cancer somewhere, what would be your first instinct to want to do? Get it out. Get it out. Get it out. Get it out. And that's everybody's instinct to do something like that. Sometimes it's actually not the best route. So what ended up happening with this PSA, prostatic specific antigen, that's the blood test, a PSA, prostatic specific antigen. There's been so much controversy in the last decade. But 2 decades before, when this test came out and men were getting this positive PSA, they were just going in and saying, remove that prostate, and let's do this and let's do that. So they had these different surgical techniques. They had and men's lives were being incredibly compromised by these procedures. So has it gotten better? Yes. Treatment has gotten better for prostate cancer, the type that really doesn't get addressed. There's now proton radiation rather than the traditional radiation that's tissue sparing. But the crime in that is that anybody who gets radiation now should all get proton radiation, except there's only a few places in the country that has the device. Northern Virginia has one, but Mayo Clinic has one down in Florida, in Jacksonville. And how many people who have cancer can go travel and stay someplace for 6 weeks? Well, especially when insurance is more expensive and insurances won't pay for it. So in a perfect world, when something does come out that's better treatment, more tissue-sparing treatment, is by far the way the best prognosis. It's kind of a shame that everybody doesn't get it, isn't it? But there's still surgeons who are making their living on just removing the prostate. Okay, so I'm bringing up all kinds of other things, but do you get what I mean? This is our challenge in medicine now. This is a real, real challenge. And how many of you all have been faced or know family members that have been faced with this type of thing, where you understand that maybe this line of treatment might not be what's considered the best treatment, but it's the only thing available in that area or that region or whatever, you get what I mean? So there's a lot of things to medicine than just knowing the details. Okay, so prostate. All right, so any questions about that now? Now that we've kind of gone through these, you kind of, hopefully, these labeling this doesn't look so crazy. The penis itself, a lot of the penis is a root of the penis, which is actually deep here. And this penis has tissue that's erectile tissue, which means it's filled with blood vessels that can dilate. And as these vessels dilate in erectile tissue, what's causing them to dilate? What's coming in? Blood. And that engorgement of blood is what leads to an erection, is this these vessels dilating and blood engorging the organ, right? So this is the penis. I think you all know. The head, what people call the head of the penis, is more accurately referred to as the gland. G-L-A-N. It does not have a D. It's not a gland. It's a glans of the penis. So this is what people call the head of the penis here. This urethra should open. This urethral orifice should be at the tip of the glans. Sometimes it is not. Sometimes it is tucked under. Does anybody know what that's referred to as? Sometimes males are born this way, and typically they're going to be surgically repaired and straightened. Does anybody know what that condition is called? Hypospadias. So this is in your disorders. So the opening of the urethra should be at the tip of this. There is skin that covers the glands because the glands is incredibly sensitive. This skin is called the prepuce. What do people call the prepuce? They call it foreskin. What's the prepuce on a female? What do people call that? The clitoral hood. That's exactly what people call that, the clitoral hood, right? And it covers the clitoris. So this tissue has a function of being protective to this incredibly sensitive sensory organ. And anyway, when that foreskin's removed, do you know what the procedure's called? So it's called a circumcision. When the foreskin's removed, why would that ever be removed? That's healthy tissue that has a function. Why would it be removed?
Just
thinking about
bacteria.
Really? No. Just for,
That's not wild, but
for looks?
religious,
Why is it removed?
just religious reasons.
Well, it's definitely in the three major religions: Islam, Judaism, and Christianity. It's done. But there are also other religions that this practice is done, like at puberty. So it's not just on one religion or one thing. So it's not just that. But can you imagine who was the very first one that had it done? Because there was a first. There was a first person who took a male's foreskin and sliced it off. Has anybody ever seen this procedure? Who's seen it? I know some of my moms with baby boys have seen it. So you've seen this. It takes their breath away. They go into shock, right? They have a little moment that they're like in shock. So some little boys do better than others, but it's a traumatic surgical removal of healthy tissue. Whatever. There is no medical reason to do it. No. The whole idea of that it prevents infections and it keeps them from having UTIs and whatever is propaganda. The people who are keeping it going are religion and also women. It's not men, it's women who are keeping, because a lot of women, how many of you would say that you have heard this or you know that there's some women who are really prejudiced against men who have a foreskin? Have you known women who are prejudiced against that? Thank you, Maya, for saying yes. Thank you, Aaron. Nobody else talks to your girlfriends.
I've had friends that say that
Thank
sex
you,
is
dear.
better with foreskin.
It's more sensitive. There's like a big thing that like guys are going and saying like it's way more sensitive with the foreskin than without the foreskin, and they should have the right to keep foreskin off if they wanted to. That shouldn't be their parents' choice before.
In the sort of like little babies getting piercings. Okay, let's just let those people grow up and get their own choices of piercing. But anyway, let me tell you what happened, because you're bringing up a good point. And I remember this study. So a lot of stuff was going on in the 80s and 90s about male circumcision. Is there any reason to be doing this medically? Because a medical oath is that you'll do no harm. That's an oath that you take in any medical practice. You'll take that you'll do no harm. So much research has been done, so much data has been collected. So one little study came out and said that maybe men who had been circumcised, the ones who had the skin removed, sex was better for them. So then you had these males who were adults saying, it could be better. I'll voluntarily have that procedure. And they were mad. Because guess what? 100% of them were saying this happened in the 80s. I know you were saying the opposite.
Yeah.
Because guess what? That was that study that happened in the 80s. They had these adult males who went ahead and had the procedure done, and they were like, "Oh, hell to the no! This did not work the way we thought." Because think about this just logically. This is tissue that protects. When I hear women say that males uncircumcised, it's just some aesthetic thing that they don't like. Ladies, your labial folds couldn't get any cheesier. You learn how to clean folds. Is that true? It is really true. Like as young girls, we learn how to clean folds, don't we? And males that are uncircumcised learn the same as far as hygiene goes. The thing that's keeping the practice going is mostly women who think a penis should look a certain way. And that's the only, except for religion. Because in religion, and there are certainly most people Islam is the largest, right? So most people, but Christians and Jews do the same. Because of this writing that says that will be removed to show that you will raise the son in the, whatever. So whatever.
My husband
And we
actually
progress. So anyway, what'd you say?
My husband actually said that our sons were getting theirs done.
All right, so now let me tell you, in the United States, more boys are not being circumcised than are. The procedure now for male circumcision is the minority procedure because most you have to pay for it out of pocket now because it's aesthetics only. It's a cosmetic aesthetic procedure, so you have to pay for it out of pocket. Yes.
For the little baby boys, do afterwards and after it happens, do they still feel the pain? Because
It's an open wound for several days. So if you have a little boy, you understand that, there's a certain way you take care of it. There's certain things that can happen. Now, it's really rare that something happens during the circumcision, but tips of glands have been cut off. If you don't know how to care for that open wound, because it's an open wound, if you don't know how to care for it, you can get adhesion. So you all have seen where some of the skin has started to adhere, and it'll cause the tip to tilt. And then they have to be pulled out. I can't tell you how many babies I saw in the pediatric clinic that would come in, and just when you're examining them, you see, and if you can catch it early, you can tear it. You can actually do it with your fingers, but if it's not early, then you can't, and they're gonna have a torque in it. Do you get what I mean?
my son had to wait a month.
What'd you say?
He was too young. Not too young.
It was too little. He was too little to go through a wound procedure.
And like the whole weekend afterwards, he was just crying.
It's an open wound. It's an open wound. So, so you've had this. Every woman talks about her, whatever of birth. Ladies, it's nothing on us. The reason we don't remember the birthing process because that's a fetus. It's traumatic. And then you're going to do an open wound. Right? So look, I'm saying like this, like I didn't choose. I'll just share with you. I chose to have my boys circumcised, but it was because at the time, truly, it wasn't as much. It was sort of 50-50 at that time. And so I used a couple of things that if I had to do it again, I wouldn't choose that. I would not choose that. There's enough data now. There's enough data to support. There's no reason to do this. None. At the time, there was still some misleading kinds of information about certain things, but all of those have been debunked for men who know how to take care of a foreskin, which is the same way as little girls knowing how to take care of their labial folds. So I wouldn't do it again, but this is going to be, is it a really hard thing to change practice and change norms? It's such a hard thing to change norms. It really, really is, but more people are now not doing it. Now, how many of you, and I need you all to hear what I'm saying, doing a paper quick thread, but how many of you have heard of female circumcision? How many of you have heard? Raise your hands up high if you've heard of female circumcision. Okay, well, there's no such thing as female circumcision. So first I want to put that out there, because female circumcision would actually be just removing the clitoral hood. That would be female circumcision, removing the prepuce. That is not what's happening. So we need to stop calling it female circumcision, and we need to start calling it female mutilation.
Yeah, I've heard of that.
I thought
So-
I thought it was.
Yeah,
I thought it was
that's
interchangeable.
what I
No,
know.
it's not, because females, what is happening, and this is the World Health Organization says this is still the number one in our world today. I get chill bumps when I talk about this because it's so horrific. It is still the number one adverse thing that people do to other people that adversely affect women's health in our world today. More than 150 million women are known having had the procedure, which means that there are way more than that haven't been, because this procedure is typically done on little girls, not at birth, but usually little girls before like 7 or 8 years old. They go in and have this mutilation done. They have the clitoral hoods removed, but so is the clitoris. And everybody put up your little finger right now, wave it to me. That's how big the clitoris is. Now only part of it is showing, right? The rest of it is deep. They remove the entire thing. There's a hole left. No, we're not done. They also usually remove the inner hairless lip folds, the labia minor. They're removed. And they sew it down.
So they'll never be able to experience like an orgasm or anything?
Since that's a sensory organ. Now these little girls, many of them die from shock with the procedure. But the ones that survive, to actually urinate, it can take, because you know they're covering, when they sew it down, they're covering a lot of times the urethral opening. So to urinate can take 15 minutes, because imagine urinating drop by drop. Imagine the urinary tract infections that killed the ones that didn't die during the procedure, how at risk they are for urinary tract infections. Menstrual flow, drop by drop, once they hit puberty. To have sex, they have to be cut first.
Do they do that for that reason?
They do this. It's the same reason for male circumcisions. How do we know why we started it? But hey, go. The word progress means that you learn as you go. You know, so you kind of learn. Okay, wait a minute. Is that a real reason that we're doing this? For who knows why? A lot of people will kind of falsely say it is Islam, because in the Quran there is a writing that says that the female's male parts, dirty male parts, will be removed. And that will keep her from being unclean or impure. So in other words, we're going to keep these little girls pure. Now, why? Who knows what started? But let me say this: it's not just done for women that are Muslim. It's actually done in some other cultures as well. So we can't say that it is just because of religious things. But what we do know is if you work in even in the United States, if you were, and I've seen a couple of women who've been mutilated, if you ever work in any place that's urban enough in an ER, you're going to find a woman that's going to need very special care. They have a much higher risk of dying of urinary tract infections, pelvic inflammatory disease, childbirth, during childbirth, because of, to have even a child. You know, our tissues are designed for the fetus to move through, but not if they've been cut and then other tissues sewn together. They're going to have to tear, and it's going to end up causing risk of infections that can lead to septicemia, that can lead to death. So this is a horrific kind of thing that's still going on, and you will see women who need very special care for this. And it's a practice that's still going on today. We had thought it was mostly in Central and Northern Africa, but it is not. It is into the Middle East and even Mediterranean regions as well. And so it is definitely something that we, again, whatever the practices are, the women are the ones we know, though. We know enough now to know it's the women in the culture that are keeping it going, not the men. It is the women. The women think that their little girls will not be accepted, that they will be considered unclean, that they will never find a husband, that they will, you know, and until you made, you know, it's hard for us to understand, but we cannot judge other people's cultures unless we've walked in their shoes. So yeah, I'm sitting up here horrified and thinking, please, let's just don't do this anymore. But, you know, please, we have to understand their cultures and where they're coming from. I know just as many women in this country who feel so offended by male foreskin that they still have it in their heads such, I know it's not the same, but those women's minds are never going to get changed. They're never going to be changed about that. Do y'all know some of those women? But in this case, these are women who are feeling like their daughters will be ostracized from society. Is that a really hard thing to change somebody's mind about? Yeah. And it takes a lot of care, and it takes a lot of communication, and it takes a lot of understanding, and it takes time to change those types of practices that are just deeply ingrained. Mm-hmm. You know, nobody would. How many of you all went to sunrise service Sunday? How many of y'all went? It was beautiful. What a beautiful day. All right, but suppose one came to you and said, "You're not going to do that foolish thing. Stop doing that. You know, stop wasting your time. Stop doing that. There's no reason to do that." How would you feel?
Like
defensive. Well, guess what? The women are in these cultures are ignoring that too, because that has been something that is definitely rooted. Have y'all read Color Purple? Have you seen that? It's a great book. It was also a movie way back in the day, but it is a great book that you should read. But the follow-up to that was also about female mutilation. I'm not calling it circumcision because it's not. If it were truly circumcision, what would have been the only thing that got removed? The clitoral hood. And, you know, people pierce that, right? People are piercing that, doing all kinds of things. So that, I mean, that's fine. Do what you want to. As an adult with the clitoral hood, do what you want to. But anyway, but on a baby, removing the clitoris and the inner folds, and, you know, but see, we can't act like me and act like it. Because so you have to be talking to these women with this, you know, especially with real sensitivity. Because, and by the way, if you think it's just in the uneducated group, you'd be wrong. Because this practice is still going on in people who have the women and the men, mother and father of little girls. There was one documentary that had the mother and the father both had PhDs. And guess who wanted the 3 little girls? They were all of an age. They were close, both of them. They were all of an age where it was about time to have this procedure done. And guess who wanted it done? The mom. The father was adamant that he was not going to have it done because he saw how his sister had suffered. He remembered how his baby sister had suffered.
The mom had it done too.
The mom had it done. And she was so young, she didn't have memory of it. She didn't have memory of it, but she said, I'm normal. My genitalia is as normal as anyone's. But see, if you don't know something, how do you miss it? Do you know what I mean? So how do you miss something you've never had? To her, that was normal. So she was thinking that she wanted her daughters to be like her. So please don't think it's of just poor, uneducated people. It is not.
So what happens? Like, what happens if somebody comes to your clinic and this happened to them? You know, obviously they're not of age to consent. What would you do if there's like somebody's coming in for 13 or something, and then you see this?
I think religions trump a lot of, I don't know how it is in healthcare, but I know like different religion, Amish stuff, they have certain things with their religion that hinders healthcare from doing
reporting.
Yeah.
From types of reporting.
Like they're not.
This procedure, by the way, in the United States is illegal. So this couple who was in the United States for their professions, this woman and man, and their little girls, they were planning to go back to their native country to have the procedure done. Well, they weren't. She was, and he said no. And at the end of the document, I was thinking, I'm going to get those little girls. I'm going to go get them. Like, I'm going to be arrested for kidnapping these little girls, but oh my God, they were precious. And I just thought, oh my God. So we're sitting here looking, thinking that if these 3 little girls are going to be mutilated, we're going to let it happen. You know, like, can we stop this? But anyway, they did a follow-up and said that they had decided at that time to hold off on having the procedure done. And I have wondered since, though, if that wife won out and it took her girls back to her homeland and had that procedure done. I pray that they didn't. But
So
anyway.
can they not have like orgasms?
Yeah, well, can you without the clitoris? I mean, I don't know. Sorry, that was like.
Can you hear us? Like, oh.
Females are a little, females can have it's a little bit different than males. Can have multiple orgasms, right? So there's more than just clitoral orgasms, vaginal orgasms, whatever. But no, I would imagine not. Which I mean, I don't know. But see, that's that male part, that is getting removed. So yeah, because the little girls would have sexual, they think that this. Now, do men who actually get castrated still lose their sex drive though? No. I mean, I don't know. That's a whole other thing. But I don't, look, just be aware. So it's not like something you're going to be able to report because it's not done in this country, right? Now, if you thought it was done in this country, that's like a mutilation thing. If it was if it looked recent and somebody had mutilated this child or this young woman, yeah, you would have to, and y'all have to figure out what's going to be protocol for you to handle after that point. Yeah.
So, back when I had my son, like 26 years ago,
Right.
nurses, they don't educate like we do now.
I know.
Because they brought the baby in the room and all she said was, do you all want him circumcised?
Yeah.
And I was like, and my husband went, yeah, we want him circumcised.
Right.
And the first thing he said was, because I want grandkids. And I'm like, I don't even know what they're talking about. I didn't know. And they brought him back and he was circumcised.
Right.
But my thing was, because we want grandkids, so.
Who said that?
My husband.
Your husband. So maybe your husband didn't understand it has nothing to do with, yeah.
Grandkids.
Well, you know, and thank you, Charlotte, for bringing this up, because, you know, people, and you all are the medical people who will use terms like circumcision and use terms that some people have never heard those kinds of terms. So, and your husband might have thought that this was actually something that was going to keep him from having children in the future. Nothing, not understanding that it was just removal of the foreskin and nothing to do with like castrating, right? So he might have misinterpreted that what she said for something that would affect reproduction. And we throw out terms, you know, a lot in medicine that people don't understand. Please be looking for those clues on their faces and explain procedures. If you use a term that you think somebody's never heard of before, please explain it. Imagine how terrified your husband was thinking.
I didn't ask that when they brought him back, you know, he was.
Are you circumcised? But Charlotte, like your son is close to my son's age, and almost everybody's been circumcised then. And that was really a very common thing. And a lot of the tests, a lot of retrospective studies were being done, and a lot of new studies were being done 20 years ago. And then now we have a lot more data. And we have a lot more evidence to say that this is kind of, it is nothing like female circumcision, but it is a kind of rite passage that we have no legitimate reason for doing. And it's healthy tissue. It's healthy tissue that actually serves a function. So,
But you know, me being a nurse today, if I just went in there and said, do you want him circumcised and come back, I would get written up for that or probably lose my job. Because where I work at now, we have to explain every procedure.
well, I think that's what people deserve is the explanation. You know, they deserve it. Yeah.
So I don't have any kids, but like I'm curious, it's not something that I guess is talked about like circumcision, because like my ex-boyfriend, he didn't know what it was until I had a nephew and we were in there and they were talking about it. He's like, I don't know what that means. And I had to explain to him. And like he was like, well, wait, am I? Like he had no idea.
Yeah, like
just because it had never come up in his life. Like nobody had ever told him. And he was like 19 years old.
You're right. You can't assume that people know what these words are, these procedures. You can't. So I think it's good that people are getting, you know.
I think all of these things like that we've gone through with anatomy and physiology for both 1 and 2, I've noticed how disappointed I have been with the, like, I'm going to say the public, you know, education system, because that's where I was first introduced to all of anything body-wise is like in that system. And I think the education kind of like laxed on that. And I was like just surprised at how much I didn't know because of that.
It's so, and see, the good news is we've come a long way. We've come a long way. But the news is that we have a long way to go. And I really do think people just don't give children enough credit. Children would understand their anatomy. We can demystify anatomy. I've had grown adults women who won't touch their labia to do a urine sample. Or that would never want to like really get intimate with their own bodies and just have absolutely no clue. I have had young people come in that have sexually transmitted diseases when I was working at pediatric clinics. Young early teens that were coming in with sexually transmitted diseases. They didn't understand it just because they thought you could only get those if you had like vaginal intercourse. They didn't realize that oral sex is sex, tactile sex is sex, and you can transmit many of these diseases and whatnot with that, and there is no stigma associated with any sexually transmitted disease. There's none. There should be none. Young people, it is natural that they want to experiment. It is natural that they have these feelings and these urges and desires. It is natural. Now, how they act on it needs to be responsible. And so they need to understand that with adult, with this developmental thing that happens when you're now at a developmental stage where you are wanting to have that, this is natural, these are normal feelings. And if you do this, these are some of the things that you will need to be aware of. You need to be aware of vaginal secretions. You need to be, if you're female, you need to be aware of your genitalia if you're a male. You need to be aware that with this type of activity, that these normal, endemic, and things can happen, infections. And you need to protect yourself because they're normal to be out there. So protect yourself. Realize that if you have XYZ symptom, that this may indicate A, B, and C infection, and you need as soon as possible to address it with a medical professional, right? And that just because you may be on birth control, you can't believe how many people who think because they're on birth control, they're protected against sexually transmitted diseases. So, they think that the worst thing is being pregnant. No, that might not be the case. It might be the case is having chlamydia that goes to pelvic inflammatory disease that takes you out of this world. That would be worse, right? Or having a type of, and these are natural and normal. So these are normal feelings, these are normal things, but this is what constitutes your at-risk factors. And if you aren't ready to be responsible for this, then you might want to reconsider, whatever. But you also want to know how to protect yourself. It's just amazing to me how many people really can get things through oral sex. They didn't realize that was a possibility. Young people don't realize that. And there's no judgment against that. That's just, whatever. But if they had just gotten the information, I think that would have, helped them. So many young people, they can understand cellular biology and understand what risk they're at for certain experimental drugs. Most of my adult people in my classes at the college don't understand what drug classification marijuana is in. Do y'all know classification? Is it a stimulant? A depressant? What is it? Do y'all know what it is? It's a hallucinogen. And, you'll have young people saying, that's not true. I don't hallucinate when I'm on that. Yes, it is true. I can't help the chemistry of it. It is absolutely true. And some people, will get mellow, but some people will become paranoid. How many of you know people who get paranoid? You don't know people who get paranoid smoking? Nobody in here? Mm-hmm. Yeah, they do. It is a hallucinogen. So it's a very different. It can affect your bone marrow output. It's going to drop your counts, some of your white cells. Kids know more than we give them credit for. Educate them. Give them the information. Empower them. We think by empowering them, it's going to say that we're telling them that they can go out and have sex. That's a cultural thing too. So many things say, don't teach that. Teach abstinence. Hey, guess what we are, folks? We are animals. Guess what we want to do? We want to procreate. We do. And it's just a fact. And the more information you can get around people, I think we just discount their intelligence so much. We just shouldn't. We shouldn't. You're right. You're right. And then we think we can teach fear. So what do they teach in middle school? They show all the most horrific sexually transmitted diseases. So somebody is showing some slight signs and symptoms of something. They're like, but it wasn't that. It wasn't like that picture. Yeah, that little rash didn't look like that. It didn't look as bad as that picture we saw in the 6th grade. And so they think, okay, I don't have it. Guess what happens to signs and symptoms after a while, even untreated? They go away. And guess who's still infectious? That person who doesn't have any signs and symptoms. They're still infectious. Yeah. So let's take a break. Oh man, this is a big topic. All right, but anyway, at least we've talked about that. So let's take a quick break and we'll come back. 10 minutes. How about it? Okay, so I think we've had enough of this picture, right? So anyway, a lot of these slides that we're about to look at actually just talk about some of the things we've already been discussing. But the testes being that major, the primary sex organ. So germ cells are here that end up becoming sperm, right? And then we have these special sensiticular cells that actually are going to actually be separating the testes from area. There's something, testes blood barriers. Once men make sperm are no longer considered self cells. So they have to be protected from the male's immune system. So there is, remember we talked about the blood-brain barrier? Well, there's this blood-brain barrier that also is in the testes that are going to, once sperm are actually formed, they have to be isolated from the male's immune system, or the male's immune system attacks them. If they've ever had injury to the testes that can actually breach this, or infections that breach this, then men can be infertile because they're making antibodies against their own sperm and attacking them. Now that's a rare thing, but that actually can happen.
That
Now,
happens once the sperm is formed, like as
Yeah.
soon as it just matures.
Yeah, as soon as it's forming, the male's immune system is actually attacking it.
Is that why?
So it can reduce the counts really drastically, yes.
Is that why like the testes are kind of like lower in temperature?
No, that's so great to talk about, and let's talk about that right now. So they're lower because sperm actually needs that lower temperature to actually form. If they're too warm, the sperm cannot form correctly, and they will die. So this is why, too, when you think about the scrotum, and here's a frontal section where you remove some of the layers here, you have these different muscles, the dartus and the cremaster muscles. These are going to be muscles that hold the testes up closer to the body in cold temperatures, and then relax and let the testes kind of move away from the body temperature and hotter temperatures. So we all know that happens to men, right? If they're cold, it'll pull them up closer. So really, essentially, men are incubating their testes. They're keeping them at just the right temperature. And again, this is part of the autonomic nervous system that's controlling these muscles. So men don't have to think about it, do they? And this is a natural reflex that should be happening. Some men can be sterile if their clothing's too tight, or if they're doing things like wearing, like hot tubbing. I had a friend who they had trouble conceiving. They were both doctors, by the way, medical doctors, but they were having this terrible time conceiving, and they were doing what they needed to do to try to conceive, but they were always hot tubbing. And guess what? He was cooking his sperm. And so they stopped doing that and got pregnant almost immediately after that. So sometimes it's just those kind of things. But men wearing tight clothing or underwear or whatever, that sometimes that's happened because sperm do need these cooler temperatures to finish off that process. Then I've kind of forgotten what I was talking about before then. But anyway, so as they're forming, they move into these little ductwork system and then move into this epididymis. This epididymis is this coil tube where a lot of that last process is actually finishing up in the making of sperm. When we think about sperm, before I actually talk about that. So if you think about like the right and the left, you can see how sperm would have to move all the way up, and you can see this is just referred to as the angula, but seminal vesicles secreting this ejaculatory duct that's going to end up meeting here, the prostatic urethra, and then the penile urethra. So just a different aspect of it so that you can see these accessory glands all doing what they need to do to contribute and protect the sperm. The penis itself, if we did a transverse section, we can see the tissues here. Here the urethra has been cut, so you can see how that looks. And this tissue that is going to be very susceptible to vasodilation so that blood can actually engorge the organ. The active substance that actually causes that is nitric oxide. And nitric oxide, one of the organs that is responsible for producing a ton of this are the lungs. So as the lungs, as we all realize with arousal, what happens to breathing? Yeah, so the respirations increase, but it becomes deeper, doesn't it? So this releases the nitric oxide, which actually helps with this vasodilation, relaxation of these vessels so that blood can engorge. You know what the active ingredient for Viagra and some of those other things are? Other products that you hear about on TV at nighttime? You hear on the radio?
Oh no, that's just not good. I heard that every other commercial. That's crazy.
I know, it's really marketers here for people, but it's nitric oxide is the active ingredient in many of those products. Okay. So males, I think we understand that puberty is going to be the time when you have viable sperm. Males will have ejaculations before then, before sperm's actually present, but because little boys can do that. But it's when there's viable sperm that we really consider this to be the onset of puberty. Just like for women, it's going to be the first menstrual flow. Women are going to have some of those hormones even a couple years before, so the whole process starts before the menstrual flow actually arises. But this is what we consider this to be. Men have, as far as climacteric goes, men actually go through what's considered to be a male menopause as well. Of course, the difference in males and females' reproductive futures is that once a male is fertile, if nothing happens to any of those primary or secondary structures, a male will be fertile the rest of his life, even if he ends up being over 100, right? There will still be viable sperm within each ejaculation, and a male will stay fertile. But a woman after menopause will no longer be producing eggs. So that's a very distinct difference. And that's one of the many distinct differences between males and females. But males do around the age of 50, and this is just an average, around the age of 50, men go through something called a male type of menopause. It's usually because of a surge of FSH and LH. And so sometimes men in their 40s, 50s can start feeling these, like women do sometimes, hot flashes, feelings of suffocation, and just, lack of concentration. And so when that happens, sometimes men come into your ERs thinking they're having what? Yeah, but then you rule out a heart attack, because that's always what you rule out if they're having any kind of chest pains or any kinds of suffocation things. So you rule that out. And then if that's happening kind of commonly, then you might want to suggest that they actually get some studies done, and it could be hormone related. The good news is that it usually resolves. And what really happens is their bodies kind of acclimate to it. So anyway, we had talked about the effects of FSH and LH and what they do, and the effects of testosterone. And these effects of testosterone, we know testosterone is what gives us sex drive, right? And males have testosterone, obviously, most that are from the testes that will be on a 24-hour cycle that this is actually happening. And they get it from your adrenal glands, don't they? So plenty of libido go around. Women don't have nearly the amounts of testosterone, do we? But do we need it as much as men do? Men need to be ready 24/7. And I've talked about this before. They have to be ready 24/7 because women only have a few windows of, if a woman is not taking oral contraception, hasn't had an implant, IUD, or hasn't had, the implants, or hasn't had a depo shot, or is not taking hormones. If a woman hasn't had anything like that and is on a natural type of cycle, the average is about 28-day cycle. And in that 28-day cycle, a woman is only fertile for a few hours. So women need to have sex drive, but not nearly like men, because men might meet somebody today, this morning, that is fertile, and they have to be ready. So they may meet somebody tonight. I'm not saying it shouldn't do all this, but I'm just telling you, so they have to be, we're animals, and they have to be ready 24/7. I honestly don't know how you think about anything. Because if you think about ladies, like when you really have the drive, it's hard to think of something else, right? So imagine how they feel 24/7. I'm surprised they get anything done. So, no, just kind of joking, but not joking. They truly do have that, and that is a natural, normal thing that they live with. And it's a 24-hour cycle. Women have a 28-day cycle where our hormones are cycling in 28 days. And some women are so sensitive to those 20, and we'll talk about that cycle. Some women are so sensitive to that cycle for a few days of a month, they really don't perform well. How many of you know, it's our friends, but how many of you know people who are like that, right? In a 28-day cycle, there's a few days of the month that they just know they can't plan, they're just going to have. Now imagine men. They have this happening on a 24-hour cycle, and they will have periods of the day that they have those same things. It's just they don't last as long. But they're going through it. It's a miraculous thing, life and all this whole thing. But anyway, so we know that men have FSH and LH. We know that the gonads producing testosterone, but also inhibin. Inhibin is going to control the FSH so that sperm counts will be controlled. Some men have too many sperm, and they can be infertile if they have too many sperm. So it's important that inhibin is also controlling. Because we said, sperm's a great thing, but can you always have too much of a good thing? Everything has to be just right? So again, this whole surging and cycling that actually happens, and men do go through a male type of menopause. They do. They're still fertile, but they can go through this, and it can be really some of them kind of disabling for them, and so they really have a tough time, just like some women do. But some women have almost no hard time during menopause, and I'm sure you all know women who went through menopause and never said a word about their hot flashes or their whatever. Okay, so impotence means erectile dysfunction. And, I'm not exactly sure where they get the numbers kind of with this, but this really has nothing to do with ejaculation. So ejaculations can still happen, and so men can still be fertile even with erectile dysfunction. If you listen to advertisements, you think all men must have some trouble, because they're really targeting those few men. Would you say? It's all over. It really kind of is. It's just all over the place, those commercials. But anyway, so mitosis, we said, is growth, regeneration, repair, development, right? That's cloning of tissues. That's for all those things. And meiosis is only happening where? In the gonads, in the germ cells. And so we get that. We understand that meiosis is going to take 2 divisions, that one cell is going to have to undergo 2 divisions. After the first division, where one cell becomes 2, the number of chromosomes has been cut in half. There's a haploid number. But all the chromosomes are in copied form. So they're like condensed in duplicate form. So those 2 cells now have to undergo division so that the DNA is in singular form. And then that is going to end up being 4 cells produced that have haploid number of chromosomes. And that's, I want to get to this these are the last 4 cells that are produced from that very first germ cell, and none of these 4 cells are alike. None of them. Mendel told us this. Mendel told us that with sexual reproduction, we understand that these gametes have a shuffling of the traits. There's terms for this, it's called crossing over and independent assortment. And Mendel told us that even with the probability of genes and traits, this thing, I want to let y'all know this, because y'all are thinking, I think I've mentioned this to you, but I want you to think about semen for a second, okay? Or if you've never seen semen, think about a teaspoon of water, okay? So, because everybody can picture a teaspoon or something, right? So a teaspoon has 5 mLs. 5 mLs is in a teaspoon, and the cc is the same as an ml. So anyway, think of a fifth of a teaspoon, a fifth, 1/5. And 1/5 of a teaspoon, there can be 50 to 120 million sperm. Now you're thinking about every teaspoon, a man from puberty to average, let's say average age 78, whatever. Every teaspoon of semen he produces in his whole life. Okay, now I want you to think about a fifth of it, having that many million sperm And no two sperm a man will create in his lifetime will be exactly alike genetically. Does that just blow your mind up? If that didn't blow your mind up, you weren't listening. You didn't hear. I lost you somewhere along the way. But that's just phenomenal, isn't it? Talk about a miracle of life and whatever. I mean, that's just wonderful to think about. Anyway, so 4 functioning sperm. Yes.
So the first split in meiosis, did I say that right? Is it
In meiosis, you've got
the first
germ.
split is going to be taking, you're going to go from 1 to 2, and then
Look right here, 1 to 2.
it's going to have, I'm trying to just make sure my math is right for the chromosome part. You're going to go from,
In meiosis,
23 pairs.
in meiosis one, the first division, you go from 1 cell to 2. The 2 cells that are created have already half the number of chromosomes.
So they're going to have 23.
Each of these have 23. But come up here with me, Andrea. They each have 23. But every one, like we're just representing one of the 23. This is us. We're in this cell. Does everybody see that Andrea and I are in this cell? Andrea and I are in this cell. And we're just one of the 23. But we've got a copy partner that we're associated with, that we're stuck to. And we can't function. She said we're so close. Is that upsetting?
No, I said I'm so confused, so.
Because we're in a copy partner. We can't function. We cannot function.
You're the
There's
first
20
meiosis. You're the germ cell right now.
No, this is the germ cell.
I'm sorry.
And we have lost our homologous partners.
Okay.
And there's only 23. We're in this one little cell right here. We're in this one little cell, and there's another little cell over there. And there's 23 chromosomes in that cell, and there's 23 of us in this cell. We're just representing one right now by showing you what's happening. But we're a chromosome that's in a duplicate form. We can't function. We cannot function. We have only 23 chromosomes, so we're in haploid number. That one's in haploid number. But all the DNA is in its duplicated form.
So we're still in a pair.
We're not in a pair. We're in a duplicate form. Not a pair. So what we have to do now is this little cell. This is us. We've got to divide again, but this time when we divide, only one of our copies will go to each of the cells. Only one of our copies will go to each of the cells. And now the chromosome's in working form.
Okay.
Do you see what I'm saying?
Yes.
I'm not going to ask you any questions about that much detail, but maybe you would just trust me. You know? So when it does it, and it's kind of confusing, I get it. So listen to this. In this germ cell here, what happens is that all the chromosomes, 46 of them, make a copy of themselves. Now now we've got 46 copied chromosomes. Copied chromosomes. So after the first division, the homologs do separate. So there's a haploid number of chromosomes, but all the chromosomes are in copied form. So it takes one more division of these two to get to 4 sperm. And that I want you to know it takes 2 divisions. The end product are 4 cells, and in a male, because this is different from a female, but in a male, all 4 of those sperm are functioning usually. Now look, men are amazing, don't love them, but here's the thing. Not every sperm they make is going to be great. So, because they're making a ton of sperm, aren't they? Like we just described how many sperm they make in their reproductive life. It's really kind of mind-boggling. Talk about overkill. That should be the definition beside overkill in the dictionary, right? No, because how many sperm does it really take to get there? Just one. No, it's not overkill. It's the way that it is. So anyway, I thought of something else. But anyway, so not all of them are right. But when you look at a semen analysis and you look at it under a microscope, most of them are good. But there can be up to 20% of them that have, like some of them missing a tail. Or ones that are missing the flagellum, the tail, the flagellum, or they don't ever make it to an egg. They're done. They're over. It's cooked. Some of them have 2 heads. not just, and just one tail that you're sort of sharing. Are they gonna make it? No. Some of them are gonna be malformed, so that's okay, and that's okay to expect that. They have a lot of them. Do you know what I was thinking of? How many of y'all have gone out, lately, and like I have this maple, those little helicopter things off of maples, and the thing, your cars are full of them, right? Your rooftops, that's one tree putting out those things, right? And if even one somehow helicopters down, it gets into the earth enough to grow up. Whatever. Okay, so I'm hungry. But I was thinking of sperm when I was like wiping my car. I was thinking, this is crazy. This is so much. This is what it's like at a macroscopic level instead of a microscopic level. I was thinking of sperm. So anyway, so let's look at semen. This is just, and I had talked to you about some normal numbers per ml. Per ml, how many sperm can be normal? If it's less than this, there may be some fertility issues. If there's more than this, could there be fertility issues? Yes. So we need to kind of just write. Look what's in semen though. Fructose, which we know is a sugar, isn't it? It's a sugar and it's going to help with sperm motility. Fibrinogen, which actually causes clotting to happen. When males ejaculate into the vagina birth canal, it would just kind of run out if there wasn't some mechanism. And by the way, when the sperm is deposited into the vagina is a harsh environment for sperm. The vagina secretions are kind of trying to protect you from that. So they would want to attack this foreign thing. So there is this kind of clotting that happens first. Now soon it will start to lyse and liquefy, but their sperm have to get out of there. They have to get out of the vagina and get through to it before they're going to have any chance of surviving. So anyway, and then also there's prostaglandins, which are hormones that are going to stimulate female peristaltic contractions, which are going to then also encourage the sperm to be able to move through the cervix. The cervix, which is the neck of the uterus, is what the cervix means, the neck. It's the neck of the uterus that extends into the vagina. The cervix is almost always shut with a thick mucus plug. Is mucus a good thing or a bad thing? Good thing. It's usually shut. But there is a window of time during a monthly cycle where there are little thinnings of the mucus that allow sperm to enter. Why is the cervix opening usually shut? To protect. Because you don't want because there's a lot of normal microbes that are good secretions in the vagina, but you don't really want those going up into your uterus. Or other things sometimes. So it's protected with that mucus plug. But there's a window of time each month that mucus plug thins and allows for sperm to be able to enter through. That when you're really looking at this physiology of this, it makes you think, how does anybody ever get pregnant? You know what I mean? Sperm have so far to go. They're going into this hostile environment, and then they've got just a tremendous way to go once they're deposited, and there's all kinds of things set up in their way, barriers that are set up in their way. Probably why men make so many sperm. But anyway, these prostaglandins can be synthesized and in the lab, and we can make these. And this is, if you've ever known women who've gone in to be induced for labor, like their cervix isn't softening or thinning enough, they will go in usually a day or so before they try to start inducing with Pitocin. They'll go in and they put in, it's called a tamponade, but tampon just means stop and flow. But in this, it's a little medical plug of synthetic prostaglandins that's the same that's in sperm and semen, and it softens the cervix. What's the old wives' tale about women who want to go into labor? What should they do? Have sex, and it's for this reason, because seminal fluid has this that can help soften the cervix and start that. Okay, and so then when they usually do that, they'll have the females come in a little bit early. They'll put that in, try to soften up, help it with the face, and then the next hours later they'll start Pitocin, which is the synthetic version of oxytocin, which does what to the uterus? Contracts it. Right. Okay, so sexual arousal. I don't ask you any questions about sexual arousal. I feel like that's almost like a different class. Most men, it all works, fine. And so anyway, but it does take erectile function to happen to be able to deliver the semen where it needs to go. And when we talk about orgasm and the climax and the discharge of semen is ejaculation. Ejaculation and orgasm aren't exactly the same thing. So sometimes that can be a problem for men. Anyway, so I'm not gonna, men too will have a period of time. Some men it's just minutes. Some men it can be longer. It can be days. But I think probably most men it's just minutes before they can have another erection, and then it takes minutes or something later. Whatever. Every man's different. So. That's the male reproductive system. How are you feeling? Pretty good? Feeling pretty good? All right. I feel like I would like to just do, can y'all hold with me another 15 minutes or so? And I want to start with the female. Now, what are y'all going to be ready for? I just don't want Thursday to be so overwhelming, okay? So I want to start a little bit with the female. Guess what this picture will be, but not for Thursday. Guess what this picture will be, though? It will be a lab, the female reproductive lab. And when we take a look at this picture, let's go ahead and take a look at this picture. This will not be Thursday. It will be the last day of class where you would label this. It might look crazy right now to you, but when we talk about all these structures. Yes. So let's go ahead and begin. When we see this bladder here, by the way, I've never had a class that the women all got their own structure. Every woman in the class got their own anatomy, right? I've never had a class that all the women got 100% of them. Okay, so maybe y'all will be the first. So this is a mid-sagittal section. Let's you be the first, and now I won't be able to say that anymore. I started saying this a few years ago, hoping that would encourage all the women in the class to get a 100, but maybe you'll be. Does this make sense? This is the bladder, and that's the urethra. If you look, this urethral little opening is in front of the vaginal orifice. Do y'all see that? The vaginal opening? Do y'all see that? I have had many women who did not understand they were two separate openings. They didn't know that. But you all know that, right? And you understand that your urinary system is completely separate from your reproductive system. But please, let's take a look and see there's really a thin wall that separates this. And actually even a very thin wall that separates the what? The vagina, which is sometimes called the birth canal, the vagina from the rectum. So, is it possible for women to be very, and it's not like you can see this area, unless you have some mirrors or something, right? Which I would encourage you all to get and look at it. You got it. But is it possible for women to have confusion about symptoms? And I hate to tell women this because sometimes women are not in the mood to hear it. But when they come in and they say, I know I have a yeast infection, which would be where? Where would that be? That would be causing vaginitis or vaginosis, right? So that would be here. They know it. Or they say, I know I have a urinary tract infection. I know I do. I do not need a pelvic exam done. Just give me what I need, right? But then they'll be shocked when we find out that no, that really isn't a urinary tract infection. You have trichomonas, which is a protozoal infection that's causing vaginosis, that's causing you to feel an urgency to urinate, but it's just because it's affecting these tissues of the urethra. And so they don't know, and they wouldn't know unless they've gotten the proper diagnosis. Hey guys, can we treat people effectively if we don't know the diagnosis, the proper diagnosis? So, I do feel sorry for women because, it's really kind of bad. But anytime there is these types of signs and symptoms, you really, to be completely sure, you need a pelvic exam. Sorry. But really kind of true. A urinalysis and then even maybe a pelvic. Sometimes after the urinalysis, if that can be really clear, and then you can just do a supervision. You might not have to actually do a complete pelvic exam, but it would only be You know, it would only be complete if people really did do that. You get that. Now, there's also something I think is coming. It's going to be a way with this. I think I'm so happy about this. Maybe some of you all will go into this specialty. Right now, we have urologists that take care of what? The urinary system. And then we have gynecologists that take care of ladies, gynecological things, right? And OBs that take care of, like, you know, delivering babies and gestations and that sort of thing. But for women, there have been some women who had issues that the gynecologist thought it was urological, and the urologist thought it was gynecological. Do you get what I'm saying? And women had delayed diagnosis of things that were affecting glands in this region or whatever. And sometimes those delayed diagnoses have terrible consequences. I've known a couple of people personally who had that issue. So right now there's kind of a new field and for women's health that is specialists are treating it all. You know what I mean? Which I am so happy of, and I think it's long overdue. Because the way that medical science has kind of gone is that we have gotten a lot of specialization, haven't we? And our specialists have just zeroed in, like with blinders, on their little specialty, and they won't see neighboring structures. But I think it's just long overdue that there's some people going in to this specialty where they are becoming experts in this entire field. There are some people women can have prolapse bladders into their vaginal cavity. They can have fistulas that end up like forming little tunnels between these areas. So, you know, this is just, you know, you want somebody to know what they're doing. All right, so we get, though, that for our purposes, we do understand that in a normal, healthy female, this urinary system is separate, isn't it? I want you to look at the clitoris. Y'all see that just like most of the penis is deep, the root of the penis, most of the clitoris is also deep, isn't it? Is it not? There's a mound of fat over the pubic area of the os coxae. Y'all remember the os coxae? And the pubic region of the hip bones join like the right and the left os coxae. Y'all like my os coxaes? Okay, hip bones. The pubic region joins by a fiber cartilage pad there. So this is referred to as that pubic symphysis. But there's a fat area over this that's protective of that bone. That's called the mons pubis. And then there's a prepuce. So there's y'all said called the clitoral hood, and it is. And this is the sensory erectile, and it is the sensory organ of the female. And the inner hairless folds of a female are the labia minor. This is Latin, isn't it? And you'll see it referred to as labia minora, but it's really just stands for minor lips, is what that stands for, the minor lips. And then the major lips are the outer lips that have pubic hair. So y'all would know those. See, we're labeling the structures. Does it all seem like it's making sense? The peritoneum is actually this lining that is isolating the abdominal viscera. So this is a peritoneal membrane here that's sort of isolating this cavity, the organs in this cavity. We have the uterus, which is a muscular site. It really is. It's an amazing muscle. But obviously where the gestation mostly takes place is going to be in this area, because after the 6th day, it's gotten to this uterus, right, and is implanted. We're only seeing one side because this is a mid-sagital section. We understand we have another ovary on this side. This is the ovary, and that ovary is going to release the egg, and it's going to have to enter into the fallopian tube, and so we have a right one and we have a left one. But this ovary here, as it releases the egg, there are these fimbriae that act like little undulating fingers that are gently encouraging the egg to move into the fallopian tube, which is a hollow muscular tube that has ciliated cells on the inside that is going to encourage the egg to move down. Fertilization, which is the event where a sperm meets the egg, that's what fertilization is the event where sperm meet the egg, happens usually right here at the mouth of the fallopian tube. Right here, right outside the ovary at the mouth of the fallopian tube, that's where fertilization occurs and the zygote's created. And then it's going to have to move all the way back down to get back to the uterus. It takes about 6 days for that to happen, right? Okay. Any questions for me so far? Am I labeling all the structures? Can y'all see this happening? So in females, FSH will usually target one ovary, the right or the left, one follicle and one ovary each month. And so that's how that happens. So look at how far sperm has to go. So sperm got deposited, and even before it got deposited, did it have a long way to go from the testes just to get out? Had a long way to go just to get out. And so now it's here. It has to move up through this opening in the cervix that's usually shut, isn't it? It's usually shut with a mucus plug. It has to move through this. It has to move all the way up through the uterus. There are going to be openings. So if you think about the uterus like this, there are openings, little tiny openings that go to these fallopian tubes. So sperm have to get in, so those openings have to travel through this. They have so far to go, poor little things. And then they have to get there, right? Fertilize the egg, and then the egg has to be moving back through. I'm exhausted just talking about it. How do y'all feel? Does that make sense? And it does. When you think about this journey, you do think, gosh, wow. It's easy to get pregnant. It's easy. Most people get pregnant the month they try. If there hasn't been any other issues, or it doesn't take too long. About 1 in 6 couples in the United States right now are experiencing some fertility issues. That's the last numbers that I looked at and saw, which I thought that was kind of high, actually, 1 in 6. But most don't have any trouble. And many people, you know, as long as they haven't been on anything artificial, keeping the reproductive system suppressed, then they typically have, you know, don't have problems. So now that I've kind of talked about these structures, and you know, we do have, this is the part of the colon, you have the rectum, you have the anus, right? And this is why we said, because of this anus area, we do know we have normal flora. The colon's filled with bacteria, we have normal flora, and this flora can be, because of just the anatomy of our genitalia, this flora can, you know, from wiping back to front, it's a bad practice, isn't it? So this can actually lead some women to having certain infections. But I hope this makes this seem like not such an overwhelming kind of chart here, and that it makes better sense. How do y'all feel about it? You feel all right? All right, and I wanted to, since we had talked a little bit, it's a clinical insight. I know y'all will read it, but I thought I would read it for basics instead of something that you might see on the test. So for sexually transmitted diseases, which we don't say with any kind of like hush, we just talk about it because it's the same thing as early childhood diseases. Nobody hushes when they say that or whatever. So but when we talk about that, we know that the most common bacterial sexually transmitted disease, which is usually asymptomatic, so people are not going to have symptoms, but can cause fertility issues. Can lead to pelvic inflammatory disease, can lead to fertility issues of the women, is chlamydia trachomatis. That is a bacterium. It's called chlamydia. Has everybody heard of chlamydia? Is it important to know that it's a bacterium? Why? Then you know how to treat it. Then it can be cured, can it? It can be treated and cured because it's a bacterium, and we can treat it with antibiotics. It can be cured, but you have to know you have it first. It's the most common bacterial transmitted disease. It's chlamydia trachomatis. Trachomatis. So that is a bacterium. There are other bacteria that cause sexually transmitted diseases. Others are gonorrhea, right? Caused from a bacterium, Neisseria gonorrhea. There's syphilis, caused from a bacterium known as Treponema pallidum. You know, you know, whatever. So y'all are just hearing something. Now, what's the most common viral transmitted? Thank you. It's human papilloma virus. A lot of people think it's herpes, but actually, if you just look at the numbers, and I think in your clinical insight opinion, you'll talk about some numbers. Most women, a lot of women have been exposed to this, which means that they may never have had a wart. Human papilloma viruses can cause warts. Warts are benign, condylomas are benign tumors in the skin. But most people who have had this virus have never had the wart. But the virus can still be in the tissues and can lead to mutational changes that we know are associated with what? Cervical cancer, penile cancer, oral and throat cancers. Most oral and throat cancers now I'm going to say most, but I don't know the exact percentage. A decade ago, I heard about 30%, but it's gone way up higher than that now. Oral and throat cancers are actually from human papilloma virus exposure. So, it can lead to mutational changes. Viruses can lead to mutational changes. Do we have an immunization for it? So we have immunizations to protect people, and with that, we know that it can protect somebody from having benign little tumors that are going to go away eventually on their own. You can also protect them from eventually having cancer. This is going to save so many lives if people would get this immunization. Yes.
Well, what happens if you have the HPV
For months? Okay, so if somebody has HPV, and like we said, it's very common. If you look at just numbers, you'll see that even if people don't have any active lesions, like these warts that are just benign tumors, that would mostly resolve on their own. They can be treated as well. Some practitioners actually are avoiding treating because they think the treatment is harsher than the progression of the disease, because the treatment is sometimes going into healthy tissue. And so it just depends on the philosophy of the practitioner and how they're going to do that. But even if you've been positive for HPV, it's still really highly recommended. They want you to get the immunization because there are dozens of strains of HPV that are out there. And you may have had one that caused a wart, and so it was an obvious thing. But you may have had it. There are others that you can come in contact with that can cause cancer. So even if you are positive, you still highly recommend it. You should get the immunization to protect you from the other strains. Oh, that's a silly question. Does that make sense? And people who are positive just need to get with a practitioner and design your plan of action as far as like going forward in treatment. Yes.
Whenever I hear of HPV, you always I hear of it saying it does nothing for men, but it's like a piece of women. So
it's not true. It can cause penile cancer. It causes throat and oral cancer as well. So it is not true. When they first, what you just said,
they recommend the boys.
Yeah, well, it caused so much confusion, and I blame CDC, the Centers for Disease Control, a little bit of mass confusion. When this first immunization came out, it was just recommended for young girls.
Yeah.
And that caused so much confusion because they were thinking, oh, like boys don't get it, which is ridiculous because that's how the world goes around, right? But it's just because it was first tested on young girls. And so then, because it was first tested on young girls, they then made the recommendation after the testing that young girls get it by a certain age. But then they realized that it was really kind of a crying shame because in those years that were the interim that we knew it could be protecting, there were young boys getting it that were developing like penile cancer, and they would have to be removed, penises removed. And so that could have been made safe. And then what we know about these cancers is it's not like cervical cancer that kills you. What kills you? And cervical cancer is one of the leading causes of cancer deaths in women. What is it that kills you? The cervical cancer does what? It metastasizes. Same thing was happening in the boys, and then it's a life-threatening thing, isn't it? It can metastasize. What we know is that people who once you make the choice to become sexually active, which is normal, then you have to have routine screenings and you have routine testing, and that's going to pick up asymptomatic infections. so the treatment can start early, because most of these things, if they're bacterial, they can be eradicated, they can be cured, right? But if they're early detection, then you can have the screenings done. So before you develop cervical cancer, you would even see that you had dysplasia, which means that they would be monitoring, right? And they would, sometimes they can do treatment where they're removing, with cryotherapy, they can remove the affected areas and hopefully, you know, address it early so it doesn't metastasize or doesn't develop. So that's the important thing. Did anybody else have something? Oh, and then herpes is another one. We know with some of these viral things, you will never eradicate them, that this will become a kind of a part of it, but you can certainly be aware, certainly you can take antivirals that do suppress some outbreaks, and then also be responsible about these communicable diseases. It's about being responsible, isn't it, and preventing spread. If there was less stigma, if there was more education, there would be so much less spread of these. And then there are protozoal, and I think I mentioned one. Trichomonas is a protozoa, Trichomonas vaginalis, that causes a trick infection. It's called a trick infection. And trick infections cause a vaginosis that is going to cause a malodorous vaginal discharge. And that discharge can be kind of frothy. It's called frothy. That's not my word. That's what they call it. But it's malodorous. It's fishy. So women's vaginal secretions should not be fishy smelling. They should be musky smelling, but not daisy smelling. And not, we talked about not douching, right? Everybody understands you never ever douche. Okay, but anyway, but fishy means that it's an indication that it could be, you know, a woman could be having an infection. And sometimes a fishy smell has nothing to do with sexually transmitted something. It's the woman's normal florazole. So there's something called bacterial vaginosis, BV. BV is a woman's normal vaginal flora has gotten out of balance. And so the normal microbes that every woman has, they're called Gardnerella vaginalis, it gets a little bit, it starts blooming a little bit too much. And this bacteria can lead to a greenish kind of discharge that again has a malodor, has a sort of fishy odor, and it can lead to itching and burning and just more of a discharge. So women's discharges change throughout the 28-day cycle, don't they? It kind of ebbs and flows, but looking at the consistency and looking at the like things like odor, that can indicate when something might not be quite right, and women need to be aware of that. Okay, so, and then obviously, you know, we've already talked about HIV infections and other things that can be transmitted through tactile, direct communication. So, good. All right. Any other questions for me about that? I think you have a clinical insight. It's really good. I'll just real quickly mention about birth control. Different types of birth control that women can handle. So women can have IUDs, which is going to be the placement of a device into the uterus area and into this endometrium. And this device is causing a slight irritation of the endometrium that doesn't allow for implantation. Is also giving off some hormones that should stop ovulation, but always. But even if ovulation happens, even if fertilization happens, it won't allow implantation into the endometrium, so that will just be lost. It's thought that most blastocysts, not most, but some say as many as half, are actually just lost anyway, just don't implant. That's just a normal, natural situations. So anyway, just because you have fertilization and just because you have this does really not consider to be pregnant until there's been implantation. So that's IUD. As most pills are going to be estrogen progesterone combination, very low doses, that just enough to make your body think it's pregnant. Because if your body thinks it's pregnant, you won't ovulate next month, and it'll prevent ovulations just enough. So just high enough, and the best ones would be, the safest ones would be oral contraception with pills. But people now have gotten so busy that they're opting for other things like depot shots and implants. People were doing the patches, but the patches had a higher risk of blood clots. People who are on any kind of hormone therapy or like birth control, you do understand your risk of stroke and other things go up. So in a best worst scenario, that women who choose this option would do oral contraception and take it correctly. Which means the same time every day. It doesn't mean like an hour late. It doesn't mean skipping on one day and taking it the next. And it doesn't mean taking any other things with it. Because other chemotherapeutics, whether it is something, an antibiotic, or whatever, can interfere with that very minimum low dose that you're on, and you could ovulate that month, which means that you could get pregnant that month. When you hear about people having failures in their birth control, it was not usually the birth control that failed. What was it? Human error. Human error. Does everybody hear that? It was human error. But the safest truly would be, as far as the hormones go, the oral contraception that you would do, but it would require discipline and lifestyle and no human error. And then it's effective. So, any other questions for me? So, okay, about that. I wanted to talk about one other thing. I'm going to let y'all go because I know you've had a lot going on today. This uterus that we said, you can have ovulation, you can have fertilization, you can have a blastocyst form, you can have it moving down, but if it doesn't implant, it's just lost and you're not pregnant. You have to have it implanted. And this endometrium, I want you all to know that this inner lining of the uterus is called the endometrium. The muscle of the uterus is called the myometrium. And this outer layer is called the peritoneum. Y'all have heard those prefixes before, haven't you? Where did y'all hear those prefixes recently? Endo, myo, and peri. With the heart, didn't you? But you heard cardium instead of metrium. Now, with metrium, this is the uterus. Now, let me say this. This endometrium, where implantation has to happen, is like a fertile field. So if that field has been cultivated, and if that field has had some topsoil laid down, think about this endometrium. If there's been some topsoil laid down, some fertilization, some plowing, some plucking up, implantation is likely, right? Mm-hmm. If implantation doesn't happen, if it doesn't catch that blastocyst, and it doesn't happen, then that topsoil layer is lost. And that's what you all call your menstrual flow, is the losing of that topsoil for that month. Now, the next month is going to have to go back up, isn't it? But there should be no hemorrhaging. This should not be like from peripheral blood. This is just the endometrial. It's actually a very special area of the endometrium called the stratum functionalis. You do not need to know that, but okay. So this is the endometrium. Guess what some women have? Meiosis. Yeah. And so what is that? It's what? It's when this endometrial, because remember y'all said that this fallopian tube is opening into this, and on the other side, there's an opening here too. Some of this endometrial tissue migrates out of those uterine tubes into the abdominal cavity. Guess what? Sometimes this endometrial tissue, it can actually move to the diaphragm. It can move to the lungs. It can move to other areas of the body. It's crazy. So some women have endometrial tissues in areas that are still going to be affected by the monthly hormone cycles. And then when the shedding is supposed to happen, is there any way for it to go? It's trapped. So it can cause, and it's usually in the pelvic region, it can cause incredible discomfort. It can cause scarring of these tissues. So endometriosis is this process of where the endometrial lining has migrated out of the uterus. And is now, this tissue is still being acted on by the monthly hormone cycles, and it can lead to some serious issues. Now let me tell you, probably all of us have a little of that happening, but we never have any problems from it. But there are, and some of us have some problems from it. Let me say this to you, and please just hear this as a final thing for today. I cannot tell you how many people I know personally who were told that they had endometriosis and they may have difficulty getting pregnant. Guess what those people heard? What they heard, and they truly did hear, they didn't hear that. What they heard was, I can't get pregnant. So guess what they told their partner or partners? Don't worry, we don't have to do birth control because I can't get pregnant. Do you know how many babies' middle names should be endometriosis? A lot. A lot. Like, I can't even tell you how many. I mean, dozens of people I know that have thought that when they heard that. Whose fault is that? Well, you know, I think it really is physicians' faults that they don't explain well enough and say, because most people with endometriosis really do not have a difficult time getting pregnant. They're going to have difficult monthly cycles, and they're going to have more pain than most people have, and they're going to have more discomfort, and they're going to have some issues. They may even have some scarring that has to be cleared up later on. But guess what? If it hasn't blocked these fallopian tubes, they will be all right. They will be able to have that thing. Yeah. So endometriosis of their ovaries would be a misinformation. Because what is endometriosis? It's the inner lining. Now, it might have migrated around the ovaries, but they don't, so that what they're talking about is the endometrium is now affecting the ovaries because it's in that area. You see what I'm saying? But it's not of the ovaries. Do you see what I mean? But it could be affecting them. It can actually be, and people, when I'm saying this, like severe, but this is rare. The severe people with endometriosis that truly are going to have it, they can have, I mean, it can be awful. Like if you look at some surgeries of people who've been opened up that have endometriosis, they can have significant scarring. I mean, it is significant. Now that is the severe cases, you know, really severe cases when they have that. I've known someone who had it in the diaphragm that caused excruciating pain in the diaphragm. So just like respiratory issues because of the endometriosis. So this particular person's symptoms were only respiratory, but that was a significant symptom, isn't it? We need to breathe without pain, don't we? That's a very weird thing. It's usually in the pelvic region that this is happening, but it can even go to muscles. It can go to isolated muscles, the endometrium can. But that's kind of bizarre, but that's what endometriosis means. There's also something called Polycystic Ovarian syndrome, and these are going to be where you have these many little cysts that are remaining on the ovaries that can affect the cyclic hormones from the ovaries. And again, these people often get told, you might have more difficulty getting pregnant. And guess what they hear? Yes. And PCOS is a middle name. It's not good, you know. So I'm just saying. But I think it's legitimate to let people know that these are reproductive organs. These are reproductive issues of the reproductive system. You may encounter X, Y, and Z, but honestly, you should make a repeat after you. You still need to practice birth control, you know. Actually, with both of these situations, hormone replacement therapy is a great treatment. It is the appropriate treatment because it can actually control that endometrium from being affected by the normal process of hormones, and it keeps it kind of stable. See what I mean? It can also control PCOS. So actually, one of the treatments is going to be trying to do hormone therapy. Anyway, okay, does that make sense? Yes. All right, so we're going to stop right here. We've talked a lot about it, so we'll have a good place to pick up. What are you doing on Thursday? The male lab, right?